Hello and welcome to My Opthal Teacher. This is the last lecture in the series on lamellar keratoplasty, and we're going to talk about DMEK, which is a type of posterior lamellar keratoplasty. So indications and contraindications are of course the same as DSEK. Please refer to the previous lecture for DSEK. Now DMEK obviates the major advantage of DSEK, that is hyperopic shift. And why is this hyperopic shift happening? Because invariably we are transplanting some amount of corneal stroma into the recipient also. So a hyperopic shift is expected because of corneal tissue addition. Donor age for DMEK is above 50 years because it is easier to harvest the tissue because the scrolls are not so tight, and of course below 70 years because we want a good endothelial cell count of above 2000 at least. So the surgical technique is discussed in 4 steps, and at the end of it there is a video. So let us begin. That's the donor preparation. Now, there is a specific technique known as scuba that is used to prepare the donor lenticule. Scuba stands for submerged cornea using backgrounds away. That is the full form. So, what they do is nothing. The cornea is just submerged in BSS, okay, or a storage medium in order to avoid artifact. And as the cornea remains submerged in BSS, the harvesting of the tissue is done. That is what the scuba is about, okay. So this is the donor rim. It is secured to the trephine. The endothelial side is up. The tissue is stabilized. Trypan blue has been used to stain the endothelium. The endothelium DM complex is scored all around the periphery with a blunt instrument. So this is the scoring being done, and this is the DM complex being peeled off. Donor tissue stained with trypan blue 0.06% for 1 to 3 minutes. One waits out before transferring it. This is to allow better visualization. So you see, this is the donor tissue, a stained donor tissue, easy to visualize. And this is an injector. So DMEK basically requires a specialized injector. Okay, so visco eject IO injectors are also being used. It has to be a material that is safe for the endothelium. It has to be a hands-free approach. It has to be of adequate caliber with a tapered tip to seal the surgical incision. So the donor lenticule is inserted into the injector. That's the second step. Third step, we prepare the recipient. What do? We create a wound, a temporal main wound, okay, at the limbus, or a tiny sclerocorneal wound, and side wounds. Then endothelium DM resection, right? So the chamber is maintained with BSS irrigation, a reverse Sinski. This is similar to DSEK. You know, the DM is scored. Area of stripping slightly larger than the planned DMEK. This is similar to DSEK, okay? Then the AC maintainer has to be switched off. Once the scored descemet membrane is out, the AC maintainer is switched out. Obviously, you have to switch it off, because if the AC irrigation is continuous, if the positive irrigation is being done and you're going to insert a donor lenticule, it's going to push out the donor lenticule through the side. Okay, common sense. So the fourth step is DMEK graft transfer. Once you have scored the DM of the recipient, you remove it, and then you inject the scroll, the DM scroll that you have prepared. Active irrigation is stopped, and the eye should be soft. The AC should be shallow. That helps to unscroll. We will see how. The entry wound is sutured. Gentle tapping is done to unscroll the tissue. Remember to keep the endothelial surface towards the iris. Center the scroll properly. So this is, see how the DM tissue has scrolled up. So this needs to be managed, and that is why it requires surgical expertise. And finally, air bubble is injected above the iris to oppose the graft. Remember, you have to stop the AC maintainer, and you have to shallow out the AC so as to enable unscrolling and centering of your lenticule. Remember, the lenticule in this case is hardly 20 microns in thickness. Inferior peripheral iridotomy preferably done beforehand. Why? Because we're going to put 100% air bubble. We need to avoid pupillary block glaucoma. Reduce the air bubble 100 to 80%. Also, please remember to put an S mark on the stromal side of DM. Now, see, DM is a transparent structure, right? So it will be a good idea to mark it, so that you know which side is the stromal and which is the endothelial. So what the eye bank people do is they put an S mark on the stromal side of the DM with the help of gentian violet for correct orientation. You don't want an inverted graft. To check the orientation, a handheld slit lamp, intraoperative OCT or endo illuminator may be used. And DMEK triple procedure is when you're doing DMEK, plus removal of cataract and IOL implantation in the same setting, just like you have a PK triple procedure. Okay. So let's just watch a video now. So this is the recipient. You see the endothelium is, you see a hazy cornea, right? So this is probably some endothelial compromise. A trephine used to mark the area that needs to be scored. Scoring of the DM being done. That's the AC maintainer, the phacoirrigation in this case. Staining with trypan blue dye. That would have stained the DM. See, the DM has been easily removed. Simple. That's the scuba technique, where the DM is being peeled off from the donor button, while the entire corneoscleral button is submerged in VSS. See how it has scrolled up? Now you will take this scroll and you will fit it, insert it into the injector, and the injector is pushed into the anterior chamber of the recipient. You have to make sure that the side is proper. The endothelial side is always on the outside of the scroll. You suture the tunnel. Now you have to open up the scroll. Okay. So shallowing of the AC being done, right? With gentle tapping movements. So several maneuvers are there. So once the scroll has been, opened up and the graft is well centered, you put 100% air bubble. So that's it. Now, I've shown you this picture because this is a tedious process, okay? And this is the most skill requiring part of the DMEK. So when you insert the scroll, it looks like this. So the desmet has folded on itself with the endothelial side on the outside, okay? So you have to straighten it. See, with gentle tapping, maybe insert a second instrument into the scroll, open it up, right? So that it is completely opened up in the proper orientation and well opposed to the recipient bed, right? This is what it should look like at the end before you insert the air bubble. So complications, intraoperative complications, donor tissue damage during graft preparation, poor visualization of donor tissue in the anterior chamber because it's a transparent scroll, very difficult to visualize unless you have stained it. Difficulty in handling and unfolding the donor tissue, a big problem. Upside down donor graft, eccentric trephination, retained DM, AC hemorrhage, lens. These are some other miscellaneous complications. Post-operatively, a graft dislocation can happen even though it is less common than DSEK. Primary graft failure, which is rare and is usually seen at 3 months. Graft rejection rates are much less when compared to PK and they have reduced over time. See 0.7% for DMEK, 9% for DSEK, and 17% rate for PK at 5 years. Pupillary block glaucoma is going to happen if PI is not done properly. Endothelial cell loss, similar to DSEK. Refractive shift, very little. Cataract are rare. Okay. Now, if you compare the two techniques of posterior lamellar keratoplasty, so DSEK is the older one, DMEK is the newer one. DMEK is more difficult. Type of procedure, this is tissue additive because you are invariably taking a small amount of stroma. The lenticule thickness in this case is about 100 microns versus tissue neutral where the lenticule thickness is about 20 microns. As a result, the induced hyperopia is there in DSEK, maybe about plus 1.5 diopters with a meniscus-shaped lenticule. No induced hyperopia in DMEK, or a very small amount, if at all. Artificial anterior chamber is required in the case of DSEK, not required for DMEK. Microkeratome required for DSEK, not required DMEK. A specialized endoglide like a Busin glide required for DSEK, not required for DMEK. This is done in turn. On the other hand, is done with the help of an injector. So this one requires an injector. Expensive instruments required for DSEK, not required for DMEK. You need just an injector and a Teflon block. Corneal thickness is increased here in this case because it's a tissue additive. This is also the reason for the hyperopia, not increased in DMEK. In interface, there is a stromal interface, yes, in case of DSEK. No stromal interface in DMEK. Endothelial cell loss is there in both. Comparable. Availability of iBank prepared lenticules is there for DSEK, but not in DMEK. In DMEK, that has to be prepared on the spot. Lateral extension of corneal stroma is possible because there is residual stroma here, whereas not there in DMEK. Stromal graft rejection, yes and no. Endothelial graft rejection can be there in both, but less than PK. Immediate post-op follow-up required more or less for both the procedures. Interface haze is there in case of DSEK because there is a stromal interface, usually not seen in DMEK. Peripheral anterior synechia can be seen in both. Centering of the donor disc is easy, but of course difficult in case of DMEK. Tendency of detachment is also more in case of DMEK. Visual recovery is faster for DMEK because it is a thinner tissue. And percentage of eyes with 6/6 or better vision is higher in case of DMEK. So, the visual outcomes in DMEK are usually 6/6, 6/9 and maybe 6/12 for DSEK. And the most recent advancement in case of posterior lamellar keratoplasty is PDEK. PDEK stands for pre-descent endothelial keratoplasty. So remember that type 2 bubble that I told you? So that is what is utilized in this PDEK, where the cleavage plane is still uh, posterior, that is between this pre-descent layer or the Duas layer and the descent membrane. So an even thinner graft in these cases. So intrastromal injection of air is done such that cleavage plane is between PDL and DM. And this is done with the help of a new surgical instrument, the PDEK clamp, which was designed by our very own Professor Harminder Dua. So the use of the PDEK clamp is that it allows controlled injection of air so that the largest possible size of PDEK can be consistently obtained. So please know about PDEK. It's not so widespread. As it's not as widespread as of course DMEK and DSEK, but you should know about it. So thank you for listening, and that completes the series of lectures on lamellar keratoplasty. I hope you learned something.